what we're going to be doing today is we're going to do a multi-level percutaneous construct, and we've already put in the guide wires. And just a little bit of a disclaimer, I'm not going to use this as an excuse, but this is the same cadaver that the robot placed in the screws, so we had to go through the same tract at those 3 or 4 levels that they did. I think it'll be okay, but a couple things that we want to start off with is this first part of the procedure, this planning part, is one of the most crucial parts, especially for scoliosis. So multi-level, you could do it for scoliosis, you could do it for trauma, you could do it for tumor. You'll note that I actually put in these numbers here. So this is really important. This is L1, 2, 3, 4, 5, and then this is S1. Let's just say that this cadaver had scoliosis, which this cadaver does not. But let's just say that the scoliosis is here, right? So sort of the left apex scoliosis. And so what we're going to do, we're going to attempt this. And again, I've not done this in a cadaver before, so I don't know if it's going to really work or not, but we'll see. But we're going to try to, if we have enough time, we're going to try to compress at the convexity of the curve. And then over here on Dr. Elias's side, we're going to try to expand on the concavity of the curve, okay? So essentially what we're going to do is we're going to use the guide wires that we just placed right now, and we're going to take turns going back and forth to put in screws from S1 to L1, and then we're going to show you how to bend the rod and to get the right length of the rod, and then we're going to show you sort of some reduction maneuvers for scoliosis, okay? So we'll start off with these screws. I'll start off with my side. Can we get a lateral view? Can you guys see that okay? Charlie, can you guys see that okay?
Yes, we can. Yeah, it looks okay, good.
Picture that. So we're going to try to see, picture that. You want to make sure on the lateral view that you're parallel to your guide wires. And normally I use power, which is a lot faster than this. So it's going to take a little bit longer. So please be patient. Picture that. So now I can feel that we're actually in bone. Mm-hmm. So once we're in bone, we're going to try to see if we can get a bicortical purchase. Picture that. And I think that these screws are long enough to get a bicortical purchase, at least at S1. Picture that. So what I'm doing is I'm controlling this guide wire so it doesn't advance, because we did actually penetrate the anterior cortex of S1 in order to get a bicortical purchase. Picture that. So we're almost down. Picture. I'm going to back this up just a little bit. And I can feel that I'm starting to get a bicortical purchase. So I'm getting a really good sense. Picture. And we may be just a little bit too low, so that you also want to take a look at the depth. I may back this up just a little bit, because otherwise it may be difficult to put in our rod at the very end. Picture that. Right there. Picture that. So I'm going to take out this guide wire. And then normally I would stimulate this screw just to make sure that we haven't violated the pedicle. So why don't we do Dr. Elias's side. Okay, go ahead. So you want to control that guide wire to make sure it doesn't advance anteriorly. So I'll help you here. Go ahead. Okay, keep on going. And then you want to hold this there. And then just kind of just finger tighten it through the soft tissues. Mm-hmm. Yep, so keep on going. Picture that. And then we want to change, yep, picture. The other way. Picture. Perfect. So Dr. Elias is kind of getting a finger sort of feel for going to the soft tissues. Once he penetrates the dorsal cortex, you're gonna start feeling a little bit getting more resistance on the bone. Picture that. So now you want to keep on, so back up the guide wire just a little bit. See how it's advanced just a tiny bit there? So we can also use, do we have a snap? Okay, picture that. Okay, that's good. Mm-hmm. So keep on advancing until your saddle or tulip gets as deep as mine on both sides. Picture that. A little bit more, about another centimeter. And you can also kind of use the depth of both of ours outside of the skin as well. Picture. A little bit more, maybe a half turn. Keep on going. Keep on going. Right there. Picture. And that's perfect, okay? So you can take this out, the guide wire, And what we're trying to do here, try to use a snap. A good way of actually, if the guide wire gets stuck, you can actually use this or a needle driver or a coker, and essentially just pull this cantilever, bend it down against this, so push this down to pull that up, okay? Great. And then you can take off the screw. And in between, I always want to make sure that the screws are kind of in the same similar sagittal plane. And one of the lines that we drew here, we drew a mid-sagittal line here. We drew the right-sided skin incision line here, and then the left-sided skin incision line here, about a centimeter lateral to the pedicle shadow. And the reason why we do that is because we want to maintain everything is within the similar sagittal plane. And what I mean by that is you'll notice that these incisions fall on this line all the way through, right? What we don't want is this. You don't want a zigzag pattern going from outside the line to inside the line to outside the line to inside the line, outside the line. I don't care how good of a surgeon you are. You could be Dr. Michael Wang, and you still won't be able to put that rod through these screws because you have to make sure that they're within the same sagittal plane. So, and it's okay to cross this line once, maybe twice, probably not. You can cross it once going from outside to inside. That's okay. We're going from inside to outside. But you don't want to cross it multiple times, because what it'll do is you'll have a pattern whereby you want these screws to line up in the sagittal plane like this, right? You'll end up with a pattern that looks like this. So you'll be forced to put in this rod in a zigzag pattern, and that's almost impossible to do. Okay? I hope that makes sense. So let's put in our next screws, and we can do this together. Oh, in between, the other thing that you can do is in between. You want to take a look at the sagittal balance of these guide wires. And this is a little bit difficult to see, but I can already tell that all of these line up here pretty well, 1 through 4. 5 is off a little bit. So I know that could be a little bit problematic. And I mentioned this to you guys. These are the screws that were placed in by the robot, right? And I got to be quite honest with you, they weren't perfect. And I'm not trying to be critical here. I'm just telling you that normally it should have a cascading effect going from mid-sagittal plane to going more coronal as you go from upper lumbar to lower lumbar and down to the sacrum, okay? So this one is actually really good down the pedicle, but these at 2, 3, and 4, it's way too mid-sagittal. And so I know that I'm gonna have a struggle trying to put this guy, at the very end, I'm gonna have a struggle putting the rod through the 4th and the 5th, but it is what it is, okay? So as long as I'm aware of that, when I get to that step, then I'm aware of that. When I get and have a difficult time putting this rod through that L5, that's what, at least I know what's going on, okay? I hope that makes sense. So why don't we both put in the screws at the same time here? Here you go. And we're gonna go through this part of it pretty quickly. And again, normally, picture. And can you change your WAG again to make it parallel? Tyler, picture that. Okay, hold it right there. That's perfect. Do you guys see that the superior end plates are sort of very parallel? So that's the view we want, you know. So we want to make each guide wire parallel to the superior end plate. Go ahead, Charlie.
One quick question.
Picture?
You know, we noticed that these incisions are horizontal rather than vertical.
Correct.
Would you care to comment on the advantages of
Hold on a
that?
second. Picture. The other way, yeah. Picture. Right there, yeah. Why don't you take that? Yeah, that's a really good observation. Charlie, the reason why that is because it's, number one, it's cosmetic, to tell you quite honestly. Langer's lines go transverse, they don't go longitudinal. So you can do either one. It really doesn't matter. You know, the orientation of the incisions makes no difference whatsoever. It's all a cosmetic thing, okay? But the second thing is, especially multi-level constructs, if I make these incisions longitudinally, they'll either have to train track kind of alternating like this, or they'll be on top of each other, and I'm gonna make one large incision on both sides, right? Which doesn't make a lot of sense. There are some surgeons that do a midline skin incision, and then they'll actually do percutaneous through the fascia, and that's perfectly acceptable. This is all just kind of like surgeon's choice, you know? Picture? Does that answer the question?
Yeah, I think so. And
Picture
for
that.
those surgeons who make that large midline incision and then perk the fascia, do
Picture?
you put a drain into that space between the fascia and the skin?
Yeah, you can. I don't put any drains in because my incisions are perk incisions.
Right.
But the surgeons who do make the more of a midline incision, hold on one second. So I want you to notice one thing. The guide wire has advanced anterior to the anterior vertebral. So we're gonna back this up. In a real case, you never wanna see that picture because the aorta and then the IVC are there. So go ahead. But to answer your question, you can put a drain there. Yeah, in that subcutaneous space, that's perfectly acceptable. There's absolutely nothing wrong with that at all. Picture? I think you gotta be like, picture? Okay, go ahead. You should be able to push down pretty hard on bone and you should capture. I think what was happening was, so this S1 blade was kind of impinging against the right angle for Dr. Elias here. So picture that. That looks great, yeah. It's starting to capture there, right?
Yeah.
That's looking really good. So get it to that same, and what I'm looking at now is that now at every single level, I'm looking at the depth of each screw. Because even just like I told you, if the screws are off on that sagittal plane, the same thing can happen in the coronal plane, right? So meaning that if the depth is off, then that's gonna affect how the rod goes in. Picture? Okay, a little bit harder. I want you to push down a little bit harder. Picture that? Yep, it's going. Try to do big turns. Great. Picture that? I think it's spinning. Can you hold on to this for a second? Picture? That slid in there. Okay. Picture? There we go. And also, again, I'm not trying to use this as an excuse, but the pilot holes that were made here, I don't know what the size of the screws were before.
We used 7.
What was it?
Yeah, we used like here 7.
But what was the diameter?
4.5.
Okay, so that may affect this because there may be osteoporotic bone here. So I want you to take this one out. So that was 5 there. And what we're trying to do at each level is then we're gonna try to line these up here. And I previously mentioned that 4 and 5 are off in the sagittal plane, so I'm keeping my eye on that just to make sure that that's actually gonna be okay, that's not gonna be a problem. Picture that. And can you come up a little bit and change the wag? Okay, go ahead and picture that. Picture. Okay. So we're at 4 right now. Picture. There we go. God, I wish I had power here.
I see a question from one
Picture.
of the students. What are your concerns about long-term
Here you go.
radiation exposure? Do you use CT navigation for MIS?
Yeah, you can use navigation. I mean, yeah, I'm not gonna lie. Like, I worry about that as an MIS guy, the amount of exposure you get, right? We're probably doing a little bit more radiation now than we normally would do, to tell you quite honestly. But yes, you can use the only thing about navigation is that typically you can only get maybe 3 or 4 levels. Picture? Okay, keep on going. Got about another 1.5 centimeters. But yes, with navigation, you can be a little bit more precise, but you do have to be careful because of the fact that it's hard to determine the sagittal balance of it. So you got to really keep a close eye on that. Maybe maybe about 0.5 centimeter more. And can I see the free driver? Is there a free screwdriver or no? Okay. No worries. One of these have to be just a little bit lower. See that? So I'm looking at S1. Picture that. And can you picture that? Okay, this one needs to go down just a little bit deeper. Picture? Picture? That's better right there. And what I'm also doing is I'm taking a look at the alignment of these and making sure that it's lordotic here. See that? And the depth of each one of these, I'm keeping a close eye to make sure that they're not also going up and down, because again, that's going to tell you that the depths are going to be off. And what can happen is that if one is too deep than the others, it'll actually pull up that screw when we're doing the reduction maneuver. So you got to kind of, on the lateral view, you got to kind of make sure that all the screws are sort of at that same level, you know? And just if I were to be critical of what we've done so far, I would say that the S1 screws are not perfectly aligned, which is fine. The purchase is great. Picture, and the S1 pedicle, as you all know, is quite large. Picture that. Picture. So we can make small little adjustments. And sort of, Charlie, the question that you asked about radiation, typically I would use power, and what I would do is I would just keep on going here. Like for this, all I can do, I can just keep on going and not get an X-ray until I got to this point right here, until I know the depth is sort of where I need it to be. Picture that. So your the angle's off. Picture that. Mm-hmm. Picture that. Try that. Yep, that looks great. Picture that. And then at L3 is where you want to be the deepest, because you know that the lordosis is most anterior or ventral at L3, right? So this is going to be the deepest screw, and I think that's probably pretty good. The other thing I look at is I not only take a look at the tulip. Oh, you're starting to bend the rod just a bit, or bend the guide wire. Picture. Okay, keep on going. Keep on going. Yep, that looks good. But I'm looking at the tips of the screws as well. Picture that. Okay, that looks much better. Keep on going about another few turns, and then I think we're good. That's good. Picture that. Perfect. Okay, we can take this out. So I'm looking both at the tulip heads, the bottom of the tulip heads, as well as the tip of each screw to determine the depth on both sides here, actually. Can you come up north a little bit? Yep, exactly. And what Dr. Elias is so key is just make sure at every single level that everything's sort of lining up, right? Mm-hmm. So 3 is deeper, and then 2 is going to be slightly more superficial than 3. Okay. Go and picture that. And now, look at this. 3 went straight up and down. Everything else we've been working cranial to caudal, right? Mm-hmm. Now we're working from caudal to cranial, because now we've sort of gone past the apex, which is at L3, right? Mm-hmm. So now we're going to be working up this way. Picture that. And I can feel it. That's soft tissue. Now I'm in bone. If I were to use power, I would just get it down to this level right here. The other thing what I don't like about using by hand, like I don't care how good of a surgeon you are, when you see me doing this, it windshield wipers. Picture that. And so when it windshield wipers, it violates the quality of the bone, right? Whereas the power, you go straight down the coaxis. Picture. So that looks pretty good. Plus, it's faster using power. So you get picture. Still have a little ways to go. Yep. But the trajectory looks pretty good there, okay? Take my last screw. And then I'll put it. Yep. Just a little bit deeper. Can you change your wag just a little bit too? Okay, picture that. That looks great. Lock it right there. Okay, so you have another centimeter to go or so. Mm-hmm. Picture that. You got about another ½ centimeter to go. Picture. Perfect. Okay, picture that. Here you go. And then I would stimulate here, like after even for my jam sheeties, I stimulate everything just to make sure we haven't violated the pedicle. So while Dr. Elias puts in his last screw, I'm going to show you how I actually contour the rod here, okay? So the first thing I do is I take a look at the distance from the most cranial and caudal screw, and then I use that as an approximation of the length of the screw. But I know that deeper, that's actually longer than proximal, right? So because it comes as an apex here, dorsally, and it gets longer here ventrally. Picture that. Picture that. The other way. Picture. Perfect. And then, so that's how we cut this as an approximation. I don't know if it's going to be perfect or not, but in any event, we took this, and then I cut the rod to the length, longer than the most cranial and caudal incision, okay? And then I put a lordosis to match the patient's anatomy, okay? Or if they have a deformity, I want to bend it to a lordosis of how I want that patient to end up. So this is a good lordosis. So this is how we bent the rod. So we're going to do the same on his, and we're going to try this. I'm going to compress on this side, so we want actually this part, because the rod is going to get longer on this side, the convexity, the side that we compress, and the side that we distract, the rod is actually going to get a little bit shorter. So we want a little bit longer rod on that side, okay? So essentially what I do is we estimated a rod length, and this is kind of long on this side, granted, but it's fine. This is on a cadaver. But we did it just to make sure we had a rod that was long enough. And essentially, there are little markers here which you can follow as you put in the rod. You can actually see where that sagittal plane is. So then I want to bend the rod along that sagittal plane, okay? And I want to make sure that the rod is being bent. So Dr. Elias is going to help me here. I'm going to keep it along the sagittal plane and keep it straight. So essentially what I do is I bend wrong way. That was my bad. So you got to make sure it's the right way, or else it's going to go into a kyphotic position. So I'm looking straight down here. I make a small bend here, and what I do is then the next part of this rod bender, I bring it to the same point where it was before, one step away, okay? And then I look down here, and I make sure that everything's in the sagittal plane. Make a small bend. Same thing again, one more. And I'm looking at this, make sure that we don't get any bends in the coronal plane. Another bend there. And you just want a nice, gentle bend. You know, there's some systems that give you machine bends, and it looks like a zigzag. I don't like that, because that's not natural. It's not anatomic. So it's here. And then once we're sort of done, you kind of want to take a look at it and see whether or not it looks like this. You want these to match up. So when you kind of put these side by side, it looks like we need to put a little bit more lordosis right there. So I want you to hold on to that. And I'll put it right there. And then, 1 second. Yeah, go and put a little bend there, tiny bend. That's good. Okay. I think that looks better. We did put a little bit of a coronal bend. That's my fault. I'll take the blame for that. So we're a little bit off here, but now when I put this down, it sort of fits along that patient's spine, right? The other thing we can do is we can take a picture there. Picture there. Picture there. So this is kind of the top of the construct. Picture there. This is the top of the construct, picture. And then go caudally. Picture. A little bit more. Picture. This is going to be way more than enough. Picture. So if you guys wouldn't mind cutting 2 more centimeters right here, so we'll put a little line right there. That'll give us an approximation. So go ahead and cut that, which will match this. We actually intentionally made that one a little bit longer, okay? So this is the part. It's like you spent all this time doing the decompression and the fusion. I'm being told we have like 5 minutes left. So we're going to try to do this pretty quickly. We may not be able to do the distraction and compression. You guys all know how to do that. But essentially what I'm trying to do is, is there a free screw? Yeah. Essentially what we're trying to do is taking this rod At every single level, I'm going to come down to the bottom of it, bring my hand down, and then slide it through the next screw, the next screw, and the next screw, okay? So I'll show you. It's easier said than done. Obviously, can I get some lights? So I'm down to the first one, and then what I'm doing is I'm guiding it through each of these screw heads. And this is one thing. So if I'm on one side of the screw, I do this, and I can manipulate this screw. Watch this. I can manipulate it. If I rotate it externally, this screw head's moving. Okay? See how this is moving? But if I rotate it internally, it doesn't move. It means that I'm not in. So I'm both visually looking down. Okay? Yeah, you can look down there, and you can see that it's actually through that screw. And what I'm doing is I'm guiding these through each one of these screw heads. Okay? I'm on 5 now. Now I'm going to do S1. So we're through. And once we're through, I push it all the way in, bring this back, and then rotate it. Picture that. Set screws. Let's put rings on all these. Okay. So go ahead and put on each one of these. Give me the blocker nuts. We're gonna jam through this quickly, guys. Show me the top. Show me the top. Show me the top. I'm sorry, the bottom, my bad. The bottom picture. And raise your machine up. Okay, that's good. It's gonna be long enough, which is good. So we're gonna provisionally put these screws in, one at a time. Why don't you put this one in there, into 3. And as we do this, I'm going to align these screws in the same similar sagittal plane, okay? Yep, next blocker nut. Picture that. And you'll notice that the rod is being reduced, okay? So what's happening is the spine is now being reduced to the rod that we contoured. Because the assumption is we've done some inner bodies, especially at the apex. You go. And then that's going to loosen up the spine a bit, right? And this rod's a little bit long, granted, but that's okay. Picture that. Okay. Next one. Picture that. See how it's reducing it down to there? Okay, last blocker nut. Go ahead, picture that. See how it's reducing it? And then when we're here, I can do the derotation maneuver. See that? So normally, if there was I'll show you this. Can you give me that rod? So normally, if this was a curve of the spine, right? What I would do is I would guide this like this rod like this. Does that make sense? Within the coronal plane. And then when I'm ready to derotate, I derotate it back to lordosis. So I turn that sagittal deformity into something that's more normal, okay? I'm sorry, that coronal deformity, and I turn it into more of a sagittal, okay? So that's how you sort of do this derotation maneuver. Same thing with here. You kind of enter it this way, and then you rotate it this way, and that straightens out the spine, okay? So that's the derotation maneuver. And then in the interest of time, what we're gonna do is we're just gonna I don't think it's worthwhile for us to do compression distraction. Everybody knows how to do that, but now there's instrumentation that allows you to do that percutaneously, okay? So let's just final tighten all these. And as you final tighten all these, we have blocker nuts and everything, right? You're gonna line all these up now to make sure that they're all kind of like this, okay? So what was kind of deformed in the coronal plane, we're gonna try to line up in the sagittal plane. So that, yep, and I'm gonna act as this counter torque. Great.
Should it click?
Yep, no, it should go to 12 Newton meters. 12. Good, yep, so keep on going. And you wanna, yep, keep that in that same sagittal plane. So we're gonna, that coronal deformity, we're turning it into a nice straight spine in the sagittal plane.
So this looks great, Jeff. I appreciate it. Are there any questions from the audience?
Back going.
You know, you may notice that as the rod is being placed, all of the pedicle screws are looking more and more overlapped, which is indicative of the correction.
Correct. That's exactly
scoliosis.
right, Charlie. And in fact, what will end up happening is when you first start off and get a lateral, the guide wires and all the screws will be like this. They'll be like this, you know? And then as you
Right.
make the correction, it'll start going like this, and then it'll all line up together. That's how I know that I've done a good correction, because what I'm doing is at every single vertebral body, I'm putting it in the same way on both sides, right? So we're gonna take this out. And so by the time you do the reduction, picture that. So that's what it looks like on the bottom. Show us the top here. By the time we're done with our correction, if all the screws end up parallel bilaterally, then I know I've done a good job. Save that, transfer that, will just give us an AP. Okay, that looks great. And then cant it towards the head, and picture that. Can you cant it towards this way? Yep. And then picture that. Okay, so that looks good. Nice work.
Yeah, it looks very nice, guys. Thanks so much.
All right, thanks.
Thank you.